I'm going to be highlighting why we need the next generation point of care tests. My name is Francis, and I am a postdoctoral fellow at the West African Center for Cell Biology of Infectious Pathogens in Ghana. So, when we compile the total human health hazards, you would find out that majority of these are attributable to infectious diseases. If you look at where they are most prevalent, it's usually the low middle income countries, specifically sub-Saharan Africa. But you'd find lots of the healthcare facilities that are condensed in urban areas, whereas majority of the population live in rural areas. Close to about 60% of the population in sub-Saharan Africa live in rural areas, whereas just about 30 to 40% live in the urban areas. But you'd find close to 70% of the healthcare facilities with good laboratory facilities all condensed in the urban areas. So there's this huge divide. So when you seek healthcare, it will depend on where you are. Are you in an urban or in a rural area? So primary healthcare, if you're in an urban area, is within 1 to 12 hours away from you. Whereas it could take up to 4 days to get access to primary healthcare. Should you require a reference laboratory, it can take you some additional 2 days if you are in an urban area, or as much as 5 days if you find yourself in a rural area. So for some unfortunate people who find themselves in really remote areas, the only access they get to diagnostics is when churches or certain corporate bodies visit their communities to have outreaches. That is the sole access to diagnostics that they come across. So I believe we've seen lots of the drawbacks of how we don't have access to diagnostic facilities in sub-Saharan Africa. But I will just put them into 3 main categories. First will be the access in itself. Next will be the quality issues. And the last will have to do with implementations. Poor implementation, like supply chain problems, and then the absence of training programs and standards, government standards that regulate laboratories for quality. So clinical laboratory diagnostics could be faced into 2 main groups. One, the under-resourced labs. What kind of research, what kind of diagnostics would they be doing compared to the resource labs? You find out that the under-resourced labs can run nothing on optical imaging techniques, molecular techniques, and serological techniques. The only option they have there when it comes to diagnostics is the use of RDTs based on immunochromatography. Compared to the resource labs, they can do any of these techniques from optical imaging, serology, molecular techniques. So, categorizing these into the various infrastructural deficiencies, you find the minimum to no labs, they have no reliable electricity, they don't have any cold storage, and they lack clean water. Compared to the labs with good infrastructure, they have all these facilities which they can run with normal regular diagnostics. Now, when it comes to the kind of samples that they can interrogate, moderate to advanced labs can work with venipunctures, like blood from venipuncture, etc., CSFs, and sputum. Whereas the minimum to no labs, they only have access to only finger prick alone. So what kind of diagnostics will these be able to do in terms of elimination and then control? Now, the RDTs, which is commonly used, have they really bridged the gaps that they are in diagnostics? Well, it's a double answer. It's both yes and no. Yes, because you have access to point of care testing. However, they have variable analytical performances. So there's a need to move away and consider alternatives. Most promising is trying to use nucleic acid amplification techniques compared to pathogen protein detection and then serological tests, which are commonly used. Nucleic acid amplification techniques offers you the advantages of early detection of the parasite DNA. Therefore, just a day after infection or just after exposure, you'll be able to detect your pathogen. Whereas you'd have to wait for about maybe 5 or a couple more days before you start detecting your antigens or your antibodies based on how your body responds immunologically. Now, molecular testing offers certain intriguing advantages which are important in NDTs. These include the changing diagnostic landscape, which requires that you have transmission in low prevalence settings. These would require molecular tests. Next, you have multiple pathogen detection. They allow you to do multiplex systems. With the advent of NGS and extra, you can probe mutations in certain protein markers. You can also track the emergence of new pathogen strains and strata. Some of the strategies that these next generation point of care tests have been applying is the use of biosensing techniques, lab chips, which are based on like microfluidics platform. So with just a drop of blood, you can channel it through various forms to interact with as many targets as possible. These allow you to probe your markers in small volumes and multiplexing. Next to be your host markers, you could distinguish between similar infections. For instance, you could distinguish between dengue and then malaria, which usually tend to present with same symptomatic like presentations. Molecular diagnostics on the increasing rise because they allow you to do drug testing. You can detect mutations and as well as rapid identification of variant strains. Digital platforms, as we had throughout today's series, are really, really encouraging in terms of developing the next generation tests for point of care. They allow you to do geographical mapping of risk areas. They can provide information regarding the disease emergence and the spread and control, as well as communicability between labs. So, revisiting the initial drawbacks of some of these lack of facilities. How can these new technologies upcoming, how can these leverage on this and trying to improve diagnostics? One, looking at the lack of electricity, new technologies could develop equipment-free or solar rechargeable battery-powered devices to try to electricity. Next to be for labs that do not have anything on cold storage and temperature control, there could be lots of integration of test processes into fast sample-to-answer devices without the need of refrigeration, etc. For working in sterile conditions, we could embed disposable cartridges that contain reagents for tests. Because of the lack of trained personnel, new technologies need to focus on automation with minimum interaction with the sample process. We can also probe analytes in easy to obtain samples. So instead of blood, the new technologies should try to probe some analytes in like saliva or sweat or even swabs. Yeah, these would also encourage uptake of diagnostics. Turnaround time is actually a very good requirement for the new diagnostic kits. Footprint and cost. The high-end expensive equipment should be avoided, and complex chemistries as well should also be avoided. In terms of data storage, digital platforms for tracking and remote monitoring of patient records should actually be integrated into many of these new upcoming technologies. One of such technologies, as you have already heard, is the laser swing platform, which has been designed by collaborators from Imperial College, Dr. Pantelis. This is a handheld molecular diagnostic tool, like a PCR kind of a thing. So instead of having a sophisticated lab where you need to have complex equipment to run PCR with electricity, this battery-powered device can just run your PCRs for you and you get your result as you would from a specialized facility. Now, compared to some RDTs and its mother real-time PCR, we can see the device is quite cheap and fulfills most of the criteria for the assured WHO criterion. So, in conclusion, closing the gaps in infectious disease surveillance and monitoring, and of course, which entities form a part, would require the development of simple, low-cost tests for use by first contact care providers. These also have to be multiplexed, paralleled, multi-analyte testing. They should also be capable of doing drug susceptibility tests. They should probe specimen in samples which are very easy to obtain. They should be at the point of care, and they should be highly sensitive molecular technologies that span the healthcare value chain. So could we say that point of care would eventually replace laboratory clinical labs? The answer is no. But if you're able to provide all these facilities, you could widen access to as much as 48%, especially 45% of the African population. So I would like to acknowledge the Digital Diagnostics for Africa Network, who made it possible for me to give this talk. Thank you.